Hi class. Today we're going to learn about physiological newborn jaundice, and hopefully this PowerPoint and the other resources I've provided you with will teach you what you should know as a practical nurse. So jaundice is often also called hyperbilirubinemia, and it's a condition that makes a newborn's skin and the white part of their eyes look yellow. It happens because there is too much bilirubin in the baby's blood, which is where the name hyperbilirubinemia comes from. And bilirubin tends to target the skin, the mucous membranes, the sclera, and brain. So jaundice is really just a yellow staining of these tissues. And bilirubin is a brownish yellow substance that is produced after red blood cells break down. And if the yellow staining gets into the basal ganglia, which is in the brain, it leads to a problem called kernicterus, and this can cause permanent brain damage. So jaundice is usually not a problem, and it's very common, but in rare cases, too much bilirubin in the blood can cause brain damage, known as kernicterus, and this can lead to hearing loss, intellectual disabilities, and other problems. So that's one reason why this subject in our course is very important for every nurse to know. So just some fast facts. Any baby can get jaundice, but it's only severe jaundice that's not treated that can cause brain damage. Jaundice affects all babies of all races and ethnicities. So in babies with darker skin, it's a little bit more difficult to detect because they already can have a bit of a golden color, but there's other ways of checking for that by looking at the whites of their eyes, and that's part of the reason why we test bilirubin levels in all babies now as a safety mechanism to prevent any babies from slipping through the cracks. Newborn physiological jaundice actually affects 60% of newborns, and it affects even more premature newborns. All babies should be checked for jaundice in the hospital, like I said, by doing blood work for a bilirubin test before they're discharged. So in my years as a nurse on maternal child care unit, that process has gradually come into effect. So before, we only did the blood test on the babies that appeared to have a lot of yellowing or signs and symptoms, and now it's a standard of care in Canada that we test all the babies for bilirubin while they're in the hospital at least one time before discharge. So why do babies develop jaundice? So all of us have some bilirubin in our blood. Before birth, the mother's liver gets rid of the bilirubin for the baby. So jaundice occurs because the baby's body ends up having more bilirubin than it can get rid of. That's the simplest way of explaining it. And where does the bilirubin come from? Bilirubin is one of the breakdown products of hemoglobin. And so as red blood cells destruct, bilirubin is one of the breakdown products. So bilirubin leaves the body through urine and stool, and like I said, during pregnancy, the bilirubin is removed through the placenta, and after birth, the baby's body must get rid of the bilirubin on its own. So after birth, like I said, the baby's liver takes over. But sometimes it takes a few days or more for the baby's liver to work well enough. And the baby may develop jaundice during this time. And then babies can also become dehydrated easily, especially if they're breastfeeding and their feedings are spaced too far apart, or they're not latching properly, so they're not actually getting nutrition or enough nutrition. This lack of milk in their body makes it harder for them to get rid of waste. Like I told you, bilirubin is excreted in stool mainly, and some of it in urine. So if a baby is not eating and drinking enough, they're going to be pooping and peeing less, and therefore this can change the way the body removes the bilirubin, and then even more bilirubin builds up. So that's why feedings are very important, and effective breastfeedings, or if they're formula feeding, making sure that they're feeding adequately and frequently enough. So they're less, and therefore this can change the way the body removes the bilirubin, and then even more bilirubin builds up. So that's why feedings are very important, and effective breastfeedings, or if they're formula feeding, making sure that they're feeding adequately and frequently enough. So there are different types of bilirubin circulating in the blood serum. There's unconjugated and conjugated. So the unconjugated bilirubin is fat soluble and therefore more potentially toxic since it can bind to the tissues. And that's known as indirect bilirubin. So when you look at the blood work for bilirubin on a baby that you're testing to see how jaundiced they are, you're going to see an indirect bilirubin and a direct. So most of this bilirubin, this unconjugated bilirubin, is bound to albumin and transported to the liver. And the unconjugated bilirubin is the type that we most commonly see in newborns that gets high. So when we look at the blood work, when you're on maternity doing your rotation, and the nurses say the bilirubin was 150 or 120 or 250, they're talking about the indirect bilirubin, which is the unconjugated bilirubin. We do also check the conjugated bilirubin, which on the lab test is called a direct. But typically that isn't abnormal, only in some rare cases where there is liver disease or something else going on that's causing the elevated bilirubin. So typically in the hospital, especially with physiological jaundice, we're more looking at the unconjugated bilirubin level, which is our indirect bilirubin. So conjugated bilirubin, which is called direct, is water soluble and therefore a more stable and non-toxic form. It's easily excreted from the body via urine and stool. So like I said, unless there's some kind of pathological process going on, they have some liver disease or biliary atresia or something else, then that direct is usually normal. But in most of our babies, the indirect is going to be elevated to some degree because, like I said, most babies have a little extra bilirubin floating around because of their immature livers, and so the indirects are never usually going to be zero. When you see the blood work, they're going to be, somewhere 50, 60, 100, 200, and I'll talk about a little bit more about the lab results in a minute. So when you hear indirect bilirubin, just think that's unconjugated bilirubin, and it's fat soluble, and it can be toxic, and that's the kind that's a little bit harder to get rid of because it has to be transported to the liver. And then the direct, that one usually isn't elevated. If you see that one elevated, you're thinking, okay, there's something else going on with this baby, possibly. So we have different types of bilirubin, but we also have different types of jaundice. So there is physiological jaundice, which is the one I really want you to know about, and it is characterized by a yellow tinge of the skin that occurs after the 24 hours of life. So that part is really important. Physiological jaundice will never appear before 24 hours of life, okay? So usually you're going to see physiological jaundice happening around 2 to 4 days after birth is when you start to notice it. And that's part of your newborn assessment. Every day that you go in, you are going to be looking at that baby's skin as part of your assessment and documenting what color they are. And are they pink? Are they jaundice? Are they pale? And that is really important. So, physiological jaundice will not show up until about the second to fourth day of life, and you should not see any jaundice color in the first 24 hours of life. Okay, and if you do, that would be known as pathological jaundice. So, pathological jaundice occurs before 24 hours of age. That's why I have it in red here. I want you to really know the difference between these. It will also last beyond 2 weeks in a term infant, where the physiological jaundice usually takes care of itself within about 10 days. And pathological jaundice, like its title is, usually does come from a pathological process. And they usually have rapid rising serum bilirubin levels, and they may also have a high direct. So their unconjugated is rapidly rising, and then their conjugated is can also be elevated in some cases. So when you see a baby that's yellow before the 24 hours of age, that's telling you as a nurse there's something wrong. You might not know what it is, but you definitely need to report this assessment to your team leader or the pediatrician physician that's in charge of that baby, and this needs to be rapidly treated. And I won't go into a lot of the pathological jaundice because it's a little out of your scope for this class. And just to sum it up, they need aggressive treatment, and they might need a transfusion exchange, and many other things. So basically, I want you to know that pathological jaundice is going to be seen before 24 hours of age, and it's very abnormal, and it needs to be reported immediately. So what causes jaundice in newborns? So I kind of briefly talked about that it occurs because the baby's body has more bilirubin than it can get rid of. The bilirubin is made when the body breaks down old red blood cells. And so basically there's a few reasons why babies get jaundice. So babies have an excessive production and rapid breakdown of red blood cells. And at birth, they also have immature livers, so they're not able to conjugate the bilirubin for excretion. So their livers are a bit immature, so they're not working as effectively as they would in an older baby or person. So that's another reason. They also have decreased intestinal flora. Delayed feeding, I talked about already, can also add to the issue. If they're not getting fed enough, then they're not excreting stool and urine as much, and then the bilirubin will not be excreted, and it can even be reabsorbed into the body if they're not feeding and stooling and urinating. Also, decreased temperature and cold stress can worsen jaundice. And the higher the serum bilirubin level, the higher the bilirubin level, and the greater risk of neurological damage. So how do we know how high a baby's bilirubin is? Like I said, we do a diagnostic blood test on every baby that's born in the hospital before they go home, if the parents will consent, and that is done after 24 hours of age. So they can have this blood test at Prince County Hospital and QEH anytime after they're 24 hours of age. So typically it's done the next lab draw after 24 hours of age. So if they turn 24 hours of age at 11 o'clock p.m. on Thursday night, then the blood work would be drawn at the 7 a.m. run on Friday morning. And so the baby would be, 32 hours old or something like that. So after 24 hours of age, and that is the responsibility of the nurses to make sure that that is ordered on every baby. And then it is also the responsibility of the nurses and the physicians to check what the results were and report them. Because the physician comes and does his rounds in the morning, that blood work might not come back till the afternoon. He may not be back till the next day. If you get an abnormal result, it's our responsibility as nurses to figure out if it is abnormal and how abnormal it is, and then phone the physician for further orders and to report the laboratory findings. So this is just a bit of a visual to help you remember the causes of physiological jaundice. So too much production of bilirubin, okay? So from the breakdown of red blood cells, you get too much production of bilirubin, okay? Also, the babies have immature livers to break down the bilirubin for excretion, okay? Over here, very important, remember delayed feeding. So if a baby, that's why assisting women with their breastfeeding or making sure and checking in that the baby's being fed regularly, if it's formula feeding, is really crucial because a baby can become very jaundiced if they're not getting nutrition. And decreased temperature and cold stress. And we did talk about that in other classes, so I'm not going to go into a lot of detail about that, about why it's so important to keep our babies warm and what that does when they're not kept warm. So there are some risk factors that can definitely make the chances of a baby becoming abnormally jaundiced. So some of the situations are preterm babies. So obviously a preterm baby's liver is going to be more immature than a full-term baby's liver. So they're going to have even more difficulty with breaking down that bilirubin with their liver, their immature liver, and therefore they are at risk for that reason. Another reason why preterm babies are more at risk is because they often have feeding difficulties. Their suck-swallow coordination may not be fully developed depending how premature they are. There's all kinds of feeding issues, and then they also would have less intestinal flora. So there's all kinds of reasons why a preterm baby is more at risk for jaundice. Babies with darker skin color also are more at risk for jaundice. Large bruising. The reason why large bruising puts them more at risk for jaundice is because the large bruising is obviously an area where there was a massive number of red blood cells broken down, and therefore if they have a big caput on their head and lots of red blood cells are broken down and they have a big bruise, then that's going to put them more at risk because there's going to be more bilirubin production from the red blood cells breaking down, and therefore that increases their risk. And then I already talked about poor feeding twice, so I'm not going to go into that again. But again, I wanted to give you some visuals. So physiological jaundice treatment, basically most of the time no treatment is needed for jaundice because it usually goes away on its own, and it is a very normal process. So I don't want to misguide you guys and think that this is abnormal and scary. It's normal, but it also needs to be monitored, and parents need to be educated about it, and we all need to know the signs and symptoms. So if someone is breastfeeding, they can help reduce the jaundice by making sure they get 8 to 12 feedings in a day. So if we do the math on that, 8 to 12 feedings a day means you're feeding your baby every 2 hours for 12 feedings and every 2 to 3 hours for 8 feedings. So that is a lot of feedings. Sometimes babies with jaundice are put under fluorescent light, and this is called phototherapy. And the skin absorbs the light in this case, and this changes the bilirubin so that the body can more easily get rid of it in the stool and urine. This is usually done in a hospital, but some places, not in Prince Edward Island, they do let parents take a phototherapy Billy blanket home, and they can be treated at home. And we do have a few different types of equipment to do phototherapy with, and you'll see that when you go to do your clinical at the hospital. It's also important to maintain body temperature, and we learned about that in our other class about thermoregulation. And it is really important to monitor that babies are stooling, passing stool, and urinating. That's why the moms have their clipboards and they need to keep track, and it's the nurse's responsibility to be in that room every couple hours and checking in and saying, okay, since the last time I've been here, if they're not marking it, you're going to look at the clipboard. If you see, oh, they haven't fed the baby in hours, or they haven't marked any poops or pees today, you're going to talk to them and say, like, I noticed that you haven't fed your baby since 8 o'clock this morning. Did you forget to write that down? And, oh, yeah, I forgot about the clipboard. And then you want to keep really accurate documentation of passage of stool, feedings, and how effective they are too. And that's also why there's a place to say, was the feeding observed by the RN or the licensed practical nurse? And you want to put your initials there. If that was your patient that day, you should have at least been in and assessed one feeding at the very least. So that's part of the treatment. Temperature control, making sure they're passing stool, early effective feedings, and phototherapy is the last resort for physiological jaundice. So the nursing care we need to do with a baby with jaundice, we need to review when we come on their prenatal and labor summary for any risk factors. So when you're listening to report, you want to think about, was the baby born on time, or was it 6 weeks early, or was it 4 weeks early, because that's going to make a difference in their risk of getting jaundice. Also, you want to look at their labor summary for infant risk factors. Did the baby have to come out with vacuum suction? Did they have to use forceps to get the baby out? If they did, the baby's most likely going to have a very large bruise on their head or swelling on their head, which means that there is an increased breakdown of red blood cells, and you are knowing right there this baby's at risk for more at risk for jaundice than another baby that had a normal labor and delivery or a normal delivery due date. You're also going to daily, every shift, maybe few times a shift, observe their skin. Look at the color of it. Look at the sclera, the white of their eyes. Is it yellow? And if they are yellow, how yellow are they, and where is it on their body? Is it just on their upper part of their body, or is it moving all the way down to their feet? You need to report and document the progression of jaundice from the face to the abdomen to the legs and feet. So as it moves down into the abdomen, legs, and feet, you know that your levels are getting very high. You also need to order, monitor, and report any abnormal lab results. So like I told you, these are automatically going to be ordered on every baby when we admit the baby and do the order set on Cerner. But it is the nurse's responsibility to make sure that the lab actually come and drew it. If that's your mom and baby, you're checking in. You know that they're supposed to get blood work that day because they're past 24 hours, and you're going to be checking in and seeing, did the lab come do it or not? And then secondly, you're going to be knowing in the back of your mind that blood work's going to be back in the next couple hours. I need to go check those results. Then when you get those results, you are going to plot those on a chart or put them into the Billy tool, which is on the desktop of all the computers, and you can also Google Billy tool. And it's very simple thing you use in the computer, and anyone can use it in the world. And you just put in how many hours old the baby was and what the result was, and it will automatically bring you up a whole diagram of information, and you can print it out, and it'll say, if they were this level, you need to do this. If they were this level, you need to do this. If they were this level, it was normal, like abnormal, and when you need to do the next draw. And then typically we call the doctor and we say, I plotted newborn male of Jennifer Collins' baby, and he is in low intermediate risk at this point. The recommendation is that we do a follow-up bilirubin blood test tomorrow morning. Would you like me to order that? And the physician typically would say, yes, please, and then that nurse would do that. And you also want to monitor the response to the phototherapy if they were on phototherapy, and educate the parents about jaundice. You educate every single family about jaundice. There's a teaching sheet in the room, which I have on the website for you, that you, I have a link to it, that you go over with every single family, and you plot where their baby was when their blood work was done. And if the baby does become abnormally jaundiced and need phototherapy, you want to give emotional support for the parents, because it can be a little scary for them, and you want to make sure that you inform them and educate them and help them feel comfortable with how to manage having a baby under phototherapy. There is a little jaundice video here from CNN, and you can watch that for a little more information if you'd like. This is a picture of phototherapy, and this is very similar, almost identical to exactly what it would look like for our babies at Prince County Hospital and most likely Queen Elizabeth Hospital. So basically, you strip your baby off, except for a diaper. You want to have a diaper on to protect their ovaries and testicles. And you put eye shields on them, because obviously this bright fluorescent light, it would not be good for their eyes. You want to make sure their eyes are shut when you put the eye pads over their eyes. There's different types of goggles and pads that we have, or eye shields, I shouldn't say goggles. And so you strip the baby off completely except for diaper and eye shields, and then you put them in a nice warm isolette, and then you have a little more responsibility, because you need to make sure that the baby's temperature isn't getting too hot in the isolette, because we have those isolettes set around 32 degrees to begin with. But with that being 32 degrees and then a warm light shining in above it, the temperature can get really hot in there. So you need to monitor the baby's temperature every 2 hours is the policy, and make sure that the baby's not getting too warm, and then adjust the temperature as necessary. And you want to have the baby in there as much as possible, so they're getting that light to get it down as fast as you can. So basically, if the baby's content, you just want to take the baby out for feedings and skin to skin with the mom and dad. And this is just the graph that I was talking about. So these are found on the unit at Prince County, and I would assume Queen Elizabeth Hospital. There's also the Billy tool, which is on all the desktops, and your clinical instructor will show you. It's really simple and digital. You just put in the numbers, it does the work for you. But for example, if I had a baby, so this is your guidelines for when to start phototherapy for an infant that's 35 weeks gestation or more. So this has to be for 35 or more weeks gestation. And what you do is you plot how many hours old your baby is. So I told you, you always do the bilirubin test after 24 hours, unless you've seen that the baby was yellow in this first 24 hours. Then you would do it stat and find out what that was. So after 24 hours, so say we did it at 36 hours, and say the baby's 36 hours, and say the baby plotted right here. They're 150. Their bilirubin, unconjugated, indirect bilirubin come back at 150, and they're 36 hours old. Well, that is completely normal, okay? When you get into here, you're getting into low risk. Here, you're getting into moderate risk. And here, you're getting into high risk. And so then you plot the baby like that. Anyway, you don't have to worry much about that. I just wanted to show you it. Those are at the desk, and your clinical instructor would be showing you how to do that several times and during your rotation. And there's also the Billy tool that actually is even simpler. You just put in 2 numbers, and it will completely give you all the information that you need. And that's what we typically use now. And I will put a link to the Billy tool on my Wix website for you as well. So that's it for my slideshow. I hope that this helps to prepare you for class when you come tomorrow, and we can do a little more hands-on work with a worksheet, and hopefully this will make newborn physiological jaundice a little more clear to you. Thanks.